Next. And then this is pre-release. Start the video. Pre-release, you'll see discontinuous motion between the superficialis and the profundus. Sometimes one moves, sometimes the other moves, sometimes they move together, but it's discontinuous. Now immediately after taking the needle out, next, we repeat, we did our procedure, next, and then here's, immediately after the procedure, you see the nice motion of the tendons with respect to each other. Now we usually put a little bit of steroid behind too to make sure it doesn't scar down again. Now you can imagine if we can do this with a needle, already people are developing little hooks that you can put under ultrasound, cut it with a hook. Why not? Better than opening for surgery. Next. So that is sort of my first talk, just to show you some of the newer techniques. And now we're going to, for the sake of time, switch over to the second talk. I will tell you one slide that I left out there is the success rate for the trigger fingers. That paper from radiology had a 94% success rate, saving all those people surgery. And in my experience, it's been like that too. It's one of the most successful procedures you could do. Very rarely, 1 or 2 years later, somebody will come back and need it again, but it's a very successful procedure. Okay, so now we're going to move on to carpal tunnel syndrome. Next. Okay, so again, just like before, it can be done open or endoscopically. The endoscope adds to the morbidity. I mean, less so than an open release, but still you have to heal from the endoscope. Next. So here's the anatomy of the carpal tunnel. We have the transverse carpal ligament, also known as the flexor retinaculum, which will push on the median nerve causing the symptoms. You all know this. Next. Here is the ultrasound of the normal carpal tunnel with the nerve, the tendons deep to it, and then the retinaculum as a canopy over the nerve and tendons. Next. So here is a swollen nerve where you've lost the normal fascicular pattern of a nerve, and we have measurements, criteria for this, which we don't have to go into now. Next. But in this patient, you can see on the long axis the nerve coming from proximal to distal and markedly narrowing under the transverse carpal ligament. So what can we do?